might say that our eyes and vision are the keys to our soul. They're also the keys to really much of how we perceive the world. Today on Gracefully Graying, I am pleased to welcome as my guest Dr. Alan Spigelman, who is a well-known local ophthalmologist and surgeon. Dr. Spigelman, welcome to Gracefully Graying.
Thank you. I appreciate you having me here today.
Well, I appreciate it because this is such an important area. I know as we age, our vision definitely changes. And why don't you first tell our viewers a little bit about who you are and your background?
I'm originally from Chicago, and I went to medical school at the University of Illinois, and then left to go do an internship in internal medicine. And in thinking about it, I decided I didn't want to do internal medicine and refocus back on ophthalmology. So I went out to UCLA Hospital in California, trained there for a year, and then came back to Illinois Eye and Ear Infirmary in Chicago, where I did my residency in ophthalmology. And I decided I wanted to do an additional year of training in refractive surgery and corneal transplantation, which I did at the University of Minnesota. And then I moved here, and I've been here for the last about almost 30 years now. Practicing in ophthalmology.
Why don't you tell a little bit about the focus of your practice for our viewers so they can understand a little bit more about what you do?
Well, we certainly take care of people who are gracefully graying, and that really is the focus of our practice is older people. The major focus of our practice is surgical, and cataract surgery is probably our biggest reason that people come to see us, that we take care of people with glaucoma, different retina problems, external disease problems, dry eye, all these things that show up later in life. I also have a particular interest in refractive surgery. Now that doesn't really impact people generally in their later years, but sometimes refractive surgery is something we can use to have an additional tweaking of someone's cataract surgery if needed.
Why don't you tell us a little bit about, first of all, I don't know, you brought some models. I don't know if you want to explain the models of the eye or just start. I'd like to really start with cataracts and cataract surgery.
Sure. So I think it is helpful to kind of look at a model so that you can see what's going on. There's some main different structures of the eye. The cornea is the very front covering of the eye, and then we have the iris, the brown part of the eye in this model, and then the lens behind that. And the issue with cataract is as we age, and pretty much everybody will get a cataract if we live long enough. It's just like we can't stop the aging process. The lens goes from being clear to sometimes getting to be as cloudy as this. Now this certainly doesn't happen overnight, and in some people it happens over a number of years and sometimes not even really that aware that it's going on, though they can tell that their driving vision might be getting worse, or that their inability to see the golf ball when they're hitting it in the golf course, they can't read the text on the screen on TV any longer, or they get glare at night. So this is the most common type. We call this a nuclear sclerotic cataract, which is the main type in aging. We also have some others where we get some little spokes going through the cataract, through the lens. It's almost like having dirt on the windscreen of your car. And those are probably the two most common. Cataract surgery has evolved markedly over the last 15 or 20 years and has now become a procedure that's done 3 million times a year in this country. It's done through a small incision. Actually, the incision we make in the eye is about 2.2 millimeters. We break up this cataract with ultrasound and then replace it with a new lens implant that then focuses the vision for the distance for people. The technology with lens implants has become very interesting over the last 10 years as well.
Tell us about it.
About 15 years ago, our practice with Les Grosinger and David Gray was involved in a study looking at a multifocal lens. So not only would it allow people to see distance, but it also gave people the ability to read without reading glasses. It was called the Restore lens. It was one of the very first multifocal lenses that was out. And that lens worked out well, but it gave some people some halos at night. And so since that time, we've been working with some other lenses, and the technology has gotten better and better, and now we can offer people the ability to see distance and some intermediate vision with really nice, good, high-quality vision. And that's called the Symphony lens, and that's been out for about 3 years now. There may be additional enhancements to these lenses. I'm sure there will be over the next few years, but that really is the state of the art right now. The other part that came about that I really never foresaw was the ability to correct astigmatism. People want to know really what that is. Well, it means the eye, instead of being round, is more of an oval shape, and so that the light doesn't focus to one spot on the retina, on the macula. And the toric lenses have worked extremely well. So one of the nice things that we can do now is when patients come in for cataract surgery, in addition to removing the opacification, getting rid of the issue, we can implant a lens that will give them good vision for the distance and potentially some vision up medium range as well.
What about for reading?
Reading is a tougher one. The implants that fix the reading, so we do have lenses that do distance and reading. The issue is they get more halos at night, so more glare when they're driving. The lenses are multifocal. They have little ridges in them, and the more you have a overlay of the two disparate areas on the retina, the more glare you get. So for some people, that was an issue, and so that kind of pushed us beyond the Restore to embrace the Symphony lens. Just seems to be much easier, much better tolerated by the patients.
And I know normally what you do one eye maybe a week or two apart, and then a second eye.
Correct. Right now, we do eyes generally 2 weeks apart.
Okay.
Sometimes we'll do them a week apart, but it's nice to do the first eye, see how the lens implant ends up in terms of calculating the power of that lens that we're implanting, and make sure we really dial it in for the second eye if there's any changes that need to be made. So 2 weeks has been great. Sometimes people will come in, and because they're so nearsighted, and it's disabling to have one eye corrected and one eye that's so nearsighted, that we do them a week apart, and that's worked out very well as well.
And are there ages? I know it happens, but are there generalities as, it's more and more common in someone's 60s or 70s or 50s, or?
Why do they get it? So cataract, some people, kids can be born with cataract, and usually that's something that gets operated on very quickly in life. Not something that our practice takes care of, but cataract as an infant is a very important thing to deal with, usually within the first few weeks or months of life. But as we age, most people get it just from aging process. We're not really sure why. Some people are more predisposed to getting it earlier, generally in the 50s, 60s, 70s. But people who've taken high-dose oral steroids can speed up cataract formation. They get a specific type, what's called a posterior capsule opacification. There are some people who get genetic cataracts that develop a little earlier in life. But for the majority of us, it's something we're going to deal with in our 60s, 70s, and 80s.
So I guess just about everyone can expect meeting with you for cataract surgery at some point.
There are some lucky people who don't. I see people in their 80s and they're doing well and they're fine, but I think the majority of us who are aging are going to end up wanting to see better. Also, the procedures come so far. When I first started as a resident, people would stay in the hospital overnight. They ended up with these big cataract glasses and they couldn't really see, and cataract surgery now gives people a much greater ability to enjoy their life and see and do things. And even as we age, people want to watch TV or they want to read, and so it's been something that's great lifestyle enhancer.
Alan, tell us about glaucoma.
So glaucoma is an issue where the pressure in the eye, let me step back for 1 second. There's two types of glaucoma. There's a narrow angle glaucoma, and that issue happens because the outflow chamber of the eye is blocked. It's much more common in people who are farsighted, very farsighted. They tend to have smaller eyes, and as we age and the lens gets bigger, the cataract starts to form, it closes this little angle off. And I think I might have a little image of that, but
okay.
The fluid is made in the back part of the eye and then circulates out through the little angle right up in the corner here. What happens is the lens moves forward, the fluid can't get out, and the pressure shoots way up in the eye. Narrow angle glaucoma presents very abruptly, pain in the eye, headache, sometimes even nausea. Fortunately, it can be fixed with a laser in the office. It's something we do in the office. Typically, that solves the problem, fixes it forever. So that's that one. Hopefully, we identify it before it happens, that we see people in the office, we can identify that the angle is getting more narrow when we fix that. The second type, which is much, much more common, is open-angle glaucoma, which is why people take drops and go to the doctor's office to be monitored. In open-angle glaucoma, the issue is that the pressure for the eye is too high and ends up damaging the nerve in the eye. One of the challenges for glaucoma is that you might run a pressure of 27 and your eye's healthy, and I might run a pressure of 16 and my eye is being damaged. So it's a matter of being able to look at the pressure and also assess the optic nerve with either pictures or some different images that we take and we watch over time, or something called a visual field test, which is really a function test of the optic nerve of the eye, which people sit in a big fishbowl and push a button when they see a light out to the side. And basically no one enjoys that test, but it's very helpful for us to tell what's going on.
Was this the one where it's like a very blue light?
Yeah.
Okay.
Yeah.
Look straight, look left, look right, up, down.
Trying to find that light, exactly. Glaucoma's gone through a lot of innovation as well. So we now have a number of different classes of eye drops. So if someone is diagnosed with glaucoma, it can be a blinding disease. I mean, the most important thing is to take your drops and follow up with your doctor. But we do have a number of drops that work very well for glaucoma. The second option for glaucoma treatment is a laser in the office. And the laser works by trying to blow some of the debris that's in this little meshwork where the fluid's getting out. And that's about a 2-minute procedure and typically can help the pressure, though it doesn't tend to help it forever, but it can give us a number of years where we don't need drops or we don't have to add additional drops. And then lastly, there's different types of surgery. There is a laser we do in conjunction with cataract surgery. If someone has kind of more mild glaucoma, we might add that so that they can get off some of their drops. And then lastly, there's more invasive glaucoma surgeries that involve trying to let the fluid out of the eye on a continuous basis. And those are much more complex surgeries, and that's kind of more at the end stage of glaucoma.
What I'd like to do is kind of step back. I mean, I'm a patient of yours. I think you have a wonderful practice, a wonderful clinic with, you have a lot of people doing a lot of things. And why don't you take our viewers through what happens when someone comes to you for whether it's an annual or biannual eye check?
So it really starts with the contact with calling into the office and letting us know why someone is going to be there, whether it's a new patient or a returning patient. But essentially, after checking in, we have a group of trained ophthalmic technicians. These are people who have taken certification courses, keep up with their topics, and really are extremely good at initially taking the history, checking visions, checking eye pressures for glaucoma, and doing a basic exam so that then we can focus the rest of the exam, and when I see the patient, on the issue that really is at hand. Once the technician has examined the patient and has an idea of what we want to look at, they may come to ask me if we should order some tests based on their initial evaluation, which might include a field test that we talked about, or some other tests looking into the macula or dry eye or things of this nature. Patient's then dilated, and at that point the patient will come over to see me. And I usually start over and ask them why they're here, what brings them in, and then try to focus my exam and my discussion on the issues that they really are interested in. So the exam unfortunately takes a while to get through everything in ophthalmology because there are a lot of parts to look at, but in the end we want everyone to leave with all their questions answered and having a firm idea of what direction we're heading in.
Alan, what is macular degeneration?
So macular degeneration is an issue where the retina, or really the macula, which is the smallest part of the retina right in the center that does all the fine vision, starts to degrade over a period of years. We think macular degeneration might have a genetic component. We also know that it's related to cigarette smoking and probably general health. But macular degeneration, we generally first see it with little yellow dots in the macula. These are little aging spots. When we do notice that, we recommend patients start to take some vitamins that were looked at by the National Institutes of Health. And right now it's called AREDS2, which is vitamin C, vitamin E, zinc, copper, xanthine, and lutein. And there's a formulation where the vitamins can be purchased in the drugstore generally. Generally it's a couple pills a day. And those patients who took that formulation seem to be about 30% better overall than patients who didn't take it. So it is worth looking for these things, generally on a yearly basis after people get into their late 60s, because if we do find them, we want to start them on that. There's two types of macular degeneration. There's dry, which we just have the vitamins for, and the vitamins might slow it down. Some people can have mild macular degeneration their whole life and never progresses. Other people can unfortunately go blind from macular degeneration, or at least lose all their central vision. That's the area that's affected by the macula. Reading vision, center of the vision if you're looking at television or someone's face. There's another type, and that's called wet. And wet macular degeneration means some blood vessels are starting to grow through those little aging spots. And the problem with those blood vessels is eventually they leak. In about the last 5 to 10 years, they've developed injections that are basically vascular endothelial growth inhibitors that can be injected right into the eye. These have been extremely successful. The problem with them is frequently people have to have them every 6 to 8 weeks forever. So they are looking at ways to extend how frequently these injections need to be given, but I have seen it reverse vision loss with wet macular degeneration and keep it at bay in a number of people. So macular degeneration is a huge focus because it has affected so many people. The injections are great, but it takes a lot of work on the patient's part to keep up with everything.
What about dry eyes?
So dry eyes is another issue, certainly not generally as devastating to the eye in terms of vision health, but in terms of the number of visits we see people for, it's probably one of the more common reasons people come to the office. Dry eye can frequently present with the eye feeling wet. So if they come in and say it's teary, it's irritated, and what happens is the eye dries out to such a large extent that then it starts to tear up. Just as if you stubbed your toe or something, you get tears coming to the eye. And in fact, we'll talk about it in a second, but there's some interesting thoughts about how to get people to get some more tears. But what we've been doing for dry eye in general is artificial tears, and that increases the fluid component of the tears. Sometimes we'll do punctal occlusion. There's a little drain that drains the tears away. We can put a little piece of collagen into the little tear duct, and those last 4 to 6 months, keeps more of the fluid on the eye. We can also do that permanently. There have been some drops that people may have heard of, Restasis or Zidra, which help the eye to make more fluid. And those are twice-a-day drops. The issue with them is just that they're very expensive. And for some people who don't have coverage for their drops, it can be really overwhelming. But there is a company that's now come out with a device that you insert in your nose, creates a little electrical stimulation, you get more fluid tearing, and that's been looked at. There's some people looking at ultrasound for the eye to get the eye to make more fluid. So people are looking at some novel ways to increase tear production. The other thing I should mention about the tears is, in addition to this liquid component, there's actually a lipid component, and that comes out of the lid. The lid has little glands in it called meibomian glands. You might be able to see them right here. This is kind of the meibomian gland structure opening up into the lid margin. And that produces a lipid layer that sits on the eye and keeps the tears adherent to the cornea. So if that layer is not working as well, the dry eye can be worse. And for that, we use warm compresses generally. So
as you're blinking, is that moistening the eyes too?
Yes, it is. It's spreading the tears. So the tears actually, there's not really a duct where the tears come in. They come in all across the top part of the eye from the lacrimal gland, multiple little spots, and then the eyelid pushes it down, and then it drains out in the corner here. It kind of pushes it across. That's where they go.
Is this a product of aging, the dry eyes, or?
So I think it's definitely a product of aging. Women deal with it, I think, a little more than men. There is some thought that it could be from hormonal changes in midlife. But it is something that we generally deal with pretty well. So it can make it more difficult for people to wear their contact lenses. We see people coming in with contact lens issues as they get in their mid-late 50s. and as they get older, just irritation, just not seeing well. And it's particularly, dry eye tends to be worse in the evening because the eye's kind of moistened overnight if the eyelids close properly. And then as the day goes on, it gets more dry and gets dried out.
I'm thinking of myself. I wore contacts for many, many years, and probably about 3-4 years ago I stopped because there was more and more scratches and irritation. So that's, I guess, dry eye or aging?
It probably was the dry eye, yeah, most likely. Yeah, and sometimes it's just too much of a headache to deal with putting in a bunch of drops to keep wearing the contacts. And it's not uncommon.
Ellen, what is blepharitis?
So blepharitis kind of goes along with what we were talking about, those little meibomian glands.
Okay.
So instead of them working properly, they get plugged up and they're not producing that lipid layer that then holds the tears onto the eye. And so the eye dries out a lot more quickly. So again, that goes back to itchiness of the eye, burning of the eye, dry feeling. Warm compresses for about 4 or 5 minutes once or twice a day can be really helpful. Some people can take either a lid scrub you buy over the counter, or we can use some baby shampoo and a glass of warm water. So it's really dilute shampoo, and use that once or twice a week on the eyelid margin. And we now have an instrument in our office called the LipiFlow, which we're using in some cases. And what that does is it basically heats up the lid, which melts all the secretions within that meibomian gland, and then pumps it out. It's a 12-minute procedure. Unfortunately, it is not covered by insurance right now, but that's been helpful for some people in this case. And so this blepharitis, dry eye complex is probably the most common reason that we see people coming into the office.
What is, and I may be missing out, chalazion.
So which plays into the same thing, a sty or chalazion.
So that's a name for the sty. I mean, people get styes.
Right. So doctors, we need a bigger name for that. Sty isn't good. We like chalazion.
You could charge more for it.
Right. So a sty basically is when that meibomian gland we just talked about gets plugged. You basically get a big pimple in the eyelid. So sty presents usually with an acute swelling in the lid, redness. It can actually change your vision. If it's big enough, it pushes on the eye, causes some distortion in the vision. Generally treated with just warm compresses. Warm compresses 3-4 times a day. Drops don't really do a lot for a sty. It's like a pimple. I mean, putting drops or ointment on the pimple itself is not going to really change it. But if someone comes in with a big enough sty and they're really uncomfortable, we can do a small procedure in the office where we make an incision into it through the back and drain it out. But that's not very common. Most commonly, people go home using warm compresses.
Dr. Spigelman, we are now down to less than 2 minutes, believe it or not. And what I'd like you to do is share with us some of your recommendations for really how to take care of your eyes as we age.
I think the most important issue is to get examined once when you're in your 50s, when you turn 50 for sure. If you've never been to an eye doctor before you turn 50, you should go in. Anecdotally, I have a distant cousin who lost vision in one eye, was unaware of it until he went to the eye doctor and found he had glaucoma. So I think getting examined then, getting examined more frequently as you age is very important. I think sunglasses and ultraviolet light might be helpful as far as macular degeneration goes. The implants that we put into the eye during cataract surgery actually block ultraviolet light, so we're helping with that. But I think the main thing is being compliant with any treatment regimen your eye doctor has in mind for you, and following up at least on a yearly basis after you get into your mid to late 60s. And if you have a problem, call or go over and get it checked out without worrying about it.
Yeah, and don't ignore it, because our vision is very, very precious. And we're out of time, so Dr. Ellen Spigelman, I want to thank you so much for being my guest on Gracefully Graying, and I know there's more to cover, and I'd love to have you back.
Thank you.
And I want to thank you for watching Gracefully Graying.